Fell for that classic Washington trick of follow the smell of bacon. You did find the right room. I just apologize. It's a little healthier than you might have expected, but it is very good breakfast. Please eat up, and we might all sneak in for a little bacon afterwards. I want to welcome you to our briefing. We'll get the official title as we get launching into this. This is a briefing on short-term fixes, long-term consequences, how vaccines, viruses, and dollars impact emergency preparedness in America's cities. We are very fortunate to have, I don't know if you can sense Georgia in the room. We have a few rows of Georgia, but we also have some extraordinary co-hosts of this event that are really representing the heart of Georgia and the spirit of why cities matter to our health and preparedness in the country. I would like to first welcome our co-host, Congressman Tom Price, and please, if we get a few words from you. I don't know if you want.
I'll shout.
I have a feeling you know how to.
I'll project from here. Let me add my welcome as well. This is an incredibly important topic and an incredibly important group. My name is Tom Price. I represent the 6th District of Georgia, northern suburban Atlanta. Before I got into this crazy business, I practiced orthopedic surgery in that area for about 20 years. Spent part of my training at Grady Memorial Hospital, which is one of the big city hospitals represented here. I can't tell you how important it is to get big city hospital and healthcare right. So thanks for coming. Thanks for the work that you do. And I know sometimes when we go through the machinations of what happens here in this town, we think, oh, that'll never happen. That'll never happen. That'll never happen. When you think about that, all you have to do now is remember SGR, which nobody thought was going to get fixed ever. Nobody was paying attention to it, and it did. So that's my hopeful message. When SGR can get fixed, then anything can get fixed. So thanks for coming and attending this. Thanks for all the work that each of you do, and a special shout out to Patrice A, who's a dear friend and has done a great job for years. And I know it's going to be a great panel. Thank you so much.
Great. Thank you very much.
Yep.
We are very fortunate to have someone from the medical community in Congress with a handful, and that kind of understanding and investment is a key part to why we can keep building our public health strengths. Our other co-host is Representative John Lewis. He's not here right now, but I believe someone from his office is here to say a few words. If not, I'll do shadow puppets for a moment. All right. If he comes in, we'll take a time out to recognize his contribution as part of, again, that heart of Georgia and the work that's going on. My name's Shelley Hearn. I serve as the director of the Big Cities Health Coalition, which is part of NACCHO, the National Association of County and City Health Officials. I know you all knew that. NACCHO, not NACCHO. The Big Cities Health Coalition represents the leaders of the 27 largest health departments in the country. The urban health departments, where really it's where the rubber meets the road in so much of our health work taking place in the cities and the growing suburbs in those areas. Many of our health departments represent not just the metropolitan area, but our county health departments, which have many services, whether it's dealing with chronic disease issues or tuberculosis containment. They also are home to the emergency response of major medical events. This is very brave of all of you to be here at this hour to come and talk about a nice light topic, disasters. And I don't mean to be sounding cavalier or even catastrophic, but disasters happen. We know that they're inevitable. We don't know what they're going to be. And that's part of why it's so critical to have the investments in preparedness, which really come with an all hazards approach, so that you are prepared for whatever man-made threats come along or Mother Nature. And I think the recent events in Nepal the tragedy that is taking place there is just another reminder of the unexpected and the severity of events that can happen. The reminders that we've had in the last decade, ranging from SARS to Superstorm Sandy, have made it clear how much we need a strong public health force. Those are the laboratories, the disease detectives, the hospitals. All of them have to be training together. As Congressman Price had noted, we need to have more and more of the hospitals, public health agencies, all that infrastructure. I can say infrastructure in the basement of Rayburn, right? They need to be working together, and that's where the preparedness investments are so important. We did have those stark lessons from 9/11 and anthrax, and we have the Bush administration and this Congress to thank for the extraordinary investment that has taken place in the public health emergency response around the country. It has made a critical difference. There are no more rotary phones in our local health departments. Sounds crazy, but that was the truth at 9/11. We have more epidemiologists on the beat. We have more surveillance and countermeasures. What used to happen was in many local health departments, they were 9 to 5 weekday operations. So if a call came in about a suspected outbreak and a sample was sent over, say on a Friday night at 6 o'clock, you'd have to wait Friday night, Saturday morning. And that's right, I don't wear a watch anymore. It's the iPhone. You'd have the ticking clock going along. It'd be Saturday afternoon, Saturday night, Sunday night. It's not just the coffee. I can already feel my heart getting to go. You wouldn't be starting to get onto the job until Monday morning. And that's because we had not had the investments in capacity and infrastructure in our local health departments to often man the job. It is a much better situation today. Those days used to keep me up worrying at night. But I'll tell you, after the decades-long investment in that all-hazards approach, we are much better prepared. There are weaknesses still, but we are in a place that is in a state of readiness that we have never seen before. I know this in part because years ago I ran and founded an organization called Trust for America's Health, which was an independent public health organization that scored the states on how ready they were for a major medical event. This was not always welcomed and always wanted, but I'll tell you, it was a very clear coverage of how we were doing. We are in a better position today. But I'll tell you from this vantage point, what keeps me up now, what I think is actually our greatest risk to all the progress that we have made, is the decline that is occurring in federal emergency preparedness dollars. You can't expect to be prepared if you're cutting by almost 40% those very investments that get the job done. That's a cut that you will see resulting in reduced capacity of laboratories, less disease detectives, the epidemiologists, the drops in capabilities, and less training will be available. And we have certainly seen, whether it was Ebola, measles, how critical so many of those components are to getting the job done. At the end of the day, this kind of variation in funding is not healthy. It's a roller coaster ride that is not going to get us ready. So let me just leave you with a few thoughts that in this time of limited resources, we have to make very strategic decisions with the highest return on investment. And we need to look more and more at what our cities are doing. The cities are where leadership for much of these types of responsive events exists, in addition to the innovation of health preparedness is taking place. And while overall emergency preparedness and response funding should be increased, we need to be thinking about funding allocations that reflect the scale of the threats and the impact in these high, densely populated areas. So if you want the biggest bang for your buck, think about funding directly to the cities. Currently, only 4 cities, New York, Chicago, Washington, and LA, directly receive federal dollars for those preparedness efforts. The problem we have out there is that the CDC funding going into emergency response, CDC can't tell you how many of those dollars actually get to our cities. I can't tell you, based on those CDC dollars, what is happening and how much in the end gets to some of our key major urban areas. And that's not acceptable in this time and day. So we have before us, we'll get the kind of real stories, the insights from the front lines from 4 city leaders. We've got LA, Dallas, Fulton County, which covers lion's share of Atlanta, and also Chicago. Their insights on the recent Ebola event and measles, I think, will help us give a better sense of what worked, what didn't work, and where we need to strengthen our areas in terms of a better, stronger public health emergency response. I guess the good, the bad, and a little bit of the ugly. So let me introduce the good.
And their support for health in Fulton County. As Shelley said, the Big Cities Health Coalition is a forum for the leaders of America's largest metro health departments in the country's most urban areas. We currently have 27 members. We exchange strategies. We jointly promote and protect the nation's health and safety for a healthier America. Together, all of our members serve about 1 in 6 Americans. Our member health departments dedicated time and resources in a number of ways to address both the Ebola outbreak and the recent measles outbreaks, which the panel will speak to more specifically in just a moment. With both outbreaks, our members and our member health departments provided information and education to the public and healthcare providers, including, and I'll say a little bit more about this at the end, working to tamp down the fear surrounding Ebola and the misinformation, the lack of information based on science about the safety of routine vaccinations, such as MMR. Our member departments monitored patients with actual cases of both diseases. We did the contact tracing. For those of you who don't know, contact tracing is you have someone who's identified who has the disease. We need to go out and trace their contacts, meet with all the folks that came in contact with those folks. And so we did the contact tracing among those who may have been exposed to either disease, and in the case of Ebola, conducted airport screenings. Local health departments also coordinated with health systems and hospitals, as well as state and federal governments. They drilled to make sure appropriate measures were in place and known to staff. And they also set up incident command centers as needed. In regarding to measles, health departments provided immunizations and worked directly with schools and daycare settings to make sure that they had the information they needed and necessary immunizations to keep their students safe. Now, responding to these emergencies sometimes meant that other work didn't get done. Local health departments, even some of our BCHC members, who in most cases are better resourced than average, often operate at the margins, and both events took a majority of staff time, epidemiology staff time, and preparedness staff time, really causing other routine investigations and surveillance to be put on hold. For example, monitoring of the flu and foodborne illness outbreaks. Now, while health departments prepare for such surge activities, it still compromises their ability to conduct other important work that has real value to protecting the community and keeping it healthy. To mitigate future disruptions, we cannot emphasize enough that emergency preparedness demands a long-term approach with sustained and consistent funding rather than piecemeal funding streams. Public health departments can only be nimble and effective in response to crises if they are able to prepare and prevent, rather than being forced to play catch-up with dollars and resources after disasters occur. Now, I want to say a little bit about Fulton County. And I have to say that in this instance, I believe that in Georgia and in Fulton County, we did have our finest hour when it came to our Ebola response. Now, clearly, you all know we have great assets in the county or near the county. We have Hartsfield-Jackson International Airport, and that is a major hub for international travel. We have Grady Memorial Hospital, as Representative Price stated, and we have Emory University Hospital. So we have great assets there. Even with those great assets, it is critical for that collaboration among the local health districts, the state health districts, and the CDC, because that is another huge asset right in our backyard. And that happened with our Ebola response. There were weekly Ebola calls with the state in all of the 18 health districts in Georgia. Now, certainly with Hartsfield being a major hub for international travel, again, the metro area was probably most likely to receive a traveler. But it was really important that all of Georgia felt ready to deal with the Ebola virus disease. And so for that matter, we did have these weekly phone calls with all the districts. And it was critical because we shared information. We shared what folks were saying, what folks were worried about, what our citizens were worried about. And I believe that that really helped in our coordinated and collaborative response. I also have weekly senior team members and meetings, and I have these meetings with all of the members of my 2 health teams. In Fulton County, I'm responsible for both public health and behavioral health. Talking about the fear a little earlier, understanding that fear from a behavioral health lens was key. And so we were able to meet weekly and have those conversations because folks were coming to our clinic for their WIC services. Folks were coming to our clinic for other services, and they were worried about the Ebola virus disease. They were worried because they had heard the rumor that somebody came into a WIC clinic and had the disease. So it was important for everyone on the senior team to be informed, not just the folks that were on the front lines with Ebola, and it was important that we share that information. In addition, I report to the county manager in Fulton County. We have weekly executive leadership meetings. I raise the issue of Ebola at every one of those meetings because staff were also afraid. Staff were traveling. They had relatives who were traveling. They had relatives who were coming back, and they really wanted to know what to do. And so I was able to share accurate information at those meetings as well. Now, one of the things that we said a lot, again, was let us worry about handling this disease. But in order to do that, the citizens have to trust the response of the local health department. But we said that a lot because folks wanted to do something, and that's natural, but we said, let us do the work. We will keep you informed. We will give you the information, but let us worry and let us do the work. And I'll tell you, we got a lot of positive response from that. And I think it really went a long way to dampen down that fear that I talked about earlier. You know, some folks have asked me what best prepared me for my work in public health. And some of you know I'm a psychiatrist by training. And I have to say that training, my psychiatric training, has gone a long way as I work in public health. So again, I want to highlight that while it was our finest hour in Fulton and with the state, we did a great job with that. We're doing a great job with our vaccinations rates regarding measles. There's still more work to be done. Funding is a critical issue, as you'll hear more from the other folks and perhaps from Shelley. And so it really is a time to raise this issue of awareness. We need to be prepared at all times and not just sort of reacting to these epidemics as they come along. So I thank you again for your time this morning. And next, I'd like to introduce Wendy Chung. Since 2007, Dr. Wendy Chung has served as the Chief Epidemiologist for the Dallas County Department of Health and Human Services, the largest local health department jurisdiction in Texas, serving a population of 2.4 million. In this capacity, she has directed acute communicable disease, that's hard to say early in the morning, investigations in Dallas County, including outbreaks of cryptosporidius, pandemic influenza, H1N1, Salmonella, West Nile, and Ebola. Dr. Chung received her Bachelor's of Science degree from the Massachusetts Institute of Technology Master's of Science in Tropical Public Health from the Harvard School of Public Health, and her medical degree from the University of Texas Health Science Center at San Antonio. Dr. Chung currently serves as the chair of the Infectious Disease Committees for the Texas Medical Association and the Dallas County Medical Society. Dr. Chung.
I am Dr. Wendy Chung, and I serve as the Chief Epidemiologist for Dallas County Health and Human Services. I was asked to share with you some perspectives from the local frontline experience, and I'm happy to do so with our response to the Ebola cases diagnosed in Dallas last fall. And I will do so in sharing with you from the lens of my epidemiology role within our health department. So let me first provide some very quick background about public health agencies in our locale. In Texas, less than a quarter of the 264 counties in our state have a local health department. But since over 80% of the state's population lives in these 62 counties and cities, local health departments are the forefront agencies of public health delivery for the majority of our state's residents. Our population of 2.4 million in Dallas County renders our health department the largest local health department jurisdiction in Texas, since the city of Dallas does not have a separate health department. Epidemiologic capacity in local health departments is therefore essential for early detection, control, and prevention of major public health problems. Our department's epidemiologists have had a variety of essential roles in numerous investigations and important events in recent years, including some of the following. In 2008, we visited daily shelters in Dallas, housing thousands of evacuees displaced by hurricanes, in order to conduct outbreak surveillance and prevention. Also in 2008, we investigated a large-scale countywide outbreak of 550 confirmed cases of cryptosporidiosis, which were associated with recreational water facilities. This experience marked the first time our health department had ever used what we call an incident command system, or ICS, for an infectious disease response in order to successfully and closely coordinate our epidemiologic findings with associated environmental mitigation efforts in the 25 cities within our county. In 2009, my team and I were memorably dispatched to interview one of the first two patients diagnosed with pandemic H1N1 in the United States, a child who had flown from Dallas to San Diego. Flown from San Diego to Dallas. We conducted contact tracing interviews and obtained specimens for testing of all members in the child's Dallas household while wearing full PPE, or personal protective equipment. An ICS response structure was again used for our health department's response to pandemic influenza. And in 2012, our epidemiology staff investigated a record number of West Nile virus cases, about 398 by the season's end, with 19 deaths, prompting an unprecedented declaration of a public health emergency in our county and implementation of aerial control measures. In September of 2014, we were in the midst of reporting and investigating our state's first recognized cases of enterovirus D68 in hospitalized pediatric patients, when a traveler from Liberia with Ebola infection presented in Dallas. So in our health department, we have a very small staff of 8 epidemiologists. This is less than 1/3 of the epidemiologic workforce staffing levels that are described nationally in state health departments, where there's a median ratio of 1 epidemiologist per 100,000 population. The CDC Public Health Emergency Preparedness Program has been particularly vital for my epidemiology division, since this program supports 7 of our 8 positions. Although epidemiologic surveillance for cases has a critical role in outbreak containment, it most often will not, by itself, limit an outbreak. It is just one among several important components of an effective response, which can also include clinical case management, laboratory services, community outreach, and logistical support. Significantly, aside from epidemiology and laboratory divisions, our workforce in our Public Health Emergency Preparedness Division in our county has decreased by more than 45% since 2007. The challenges of preparing and responding to infectious disease outbreaks have been increasingly formidable in this context of declining preparedness workforce and hence infrastructure. In July through September 2014, as national health advisories about Ebola were issued, our epidemiology group additionally further disseminated these guideline documents, advisories, and Ebola-related information from CDC and professional societies locally. Here, we are indebted to the partnership of external agencies within our community, which are essential in communicating important public health messages locally. This includes our county medical society that transmits our health advisories to more than 90% of practicing physicians in our area, and our hospitals, many of which further distribute health advisories to their own medical staff membership. We also participated in planning meetings with our hospital systems in our area, and we additionally developed accessible tools such as screening questionnaires and decision frameworks for clinical testing in order to further assist our frontline clinicians in evaluating ill patients with travel history from affected countries. Our own experience with Ebola began on Sunday, September the 28th, 2014, when our on-call health department epidemiologist received notification of a patient from Liberia being seen at a local hospital. There had been prompt recognition of his potential risk for Ebola that day, given his travel history and compatible symptoms, and isolation of the patient in the emergency department. Ebola was confirmed in this patient on September the 30th with the arrival that evening of the largest CDC Epi-A team that had ever been deployed to Dallas to provide assistance. By the time of the CDC Epi-A team's arrival, our group's contact tracing activities had sequentially interviewed and identified all of the community contacts of the index case, with the exception of one household, which would be reported to us one day later. And the hospital had prepared their initial list of potential healthcare contacts. We were saddened by the passing of our index patient on October the 8th, and additionally on October the 11th and 15th, with the confirmations of secondary Ebola infections in our two nurses. These transmissions caused us to reevaluate assessments of risk levels of healthcare workers who were wearing PPE, personal protective equipment, when caring for Ebola patients, and without recognized unprotected exposures. Although there is much conjecture, as with other anecdotes of healthcare worker transmissions, there will never be the satisfaction of certainty about the exact mechanisms by which the nurses became infected. The monitoring periods for the last of the 177 contacts identified with the 3 cases was completed on November the 7th. Our 2 nurses recovered, and there were no additional transmissions among community or healthcare contacts. So among the many challenges our health department encountered during the course of this response, I want to highlight just 3, which are directly related to epidemiologic capacity in particular, since they pertain to our topic today of the importance of public health emergency preparedness infrastructure at the local health department level. First, the scale of contact tracing for this event surpassed our local epidemiologic capacity. Because the anticipated scale of continued contact tracing and monitoring would be beyond the capacity of our small numbers of epidemiology staff, the CDC Epi-A field team's ready assistance was appreciated and necessary. We had no other resources available to us for provision of this level of on-the-ground assistance and expertise. Our traditional source of some epidemiologic surge capacity in the past has been our Medical Reserve Corps volunteers, and they could not be used for this particular event. Increasing and supporting local epidemiologic staffing beyond the minimum necessary for daily routine investigations is critical to ensure capacity for outbreak responses. Secondly, we lacked important information technology capacity. Among an epidemiologist's banes are the data challenges, which are always more prominently featured during the course of an outbreak. Not only do we not have enough persons within our department for data management, we did not have a data system which could allow multiple user data entry and access, nor be easily configured for new variables, such as ongoing exposures of healthcare workers during an evolving response. Even a very well-resourced health department like New York City's described needing 12 full-time staff members dedicated to data management and monitoring healthcare contacts. Our experience was similar. CDC assistance here again was essential, as their field members comprised our entire initial data team, with CDC even providing a server on site at our center of operations at the hospital for improved data management. Long-term fixes in the form of investments in more robust IT systems locally are not achievable through singular allocations of resources, but instead they require sustained base support. And thirdly, meeting what we call the non-clinical needs of our monitored contacts particularly for those under what we call movement restrictions, those in voluntary quarantine, for example, directly impacted our epidemiology staff. Our epidemiology staff served as contact tracers who found themselves additionally tasked with spending time in the roles of assisting and relaying, coordinating, and delivering resources to meet needs of contacts, such as the needs for rent assistance, utilities assistance, assistance with procurement of food and household items. Meeting these needs was truly a community effort and also required one full-time CDC leadership-level field staff member to reach out to and coordinate local volunteer and philanthropic resources, as well as personnel outside of our usual public health preparedness division. In this case, members of our county Office of Emergency Management who dedicated much time and care arranging services for contacts. Again, maintaining sufficient preparedness workforce infrastructure within a local health department is important to retain the capacity to not only execute and coordinate necessary mobilization of local resources during response, but also to engage in the depth of planning the wide range of essential community partners to ready resources, ideally prior to emergency events. So in closing, this was an infectious disease response which underscored the collaborative strengths and intense coordination of federal, state, and our many local partners. The response needs during this event were quite clearly beyond the resources and capacity of our single local health department and agency. We valued highly the necessary support which was provided to us on many fronts by the over 30 CDC field team members who worked tirelessly alongside our teams, CDC EOC assistance from Atlanta, and our state health department preparedness staff. That the keys to genuinely achieving lasting, long-term solutions for some of the needs noted during this response are commitments and investments to strengthen the capacity for frontline preparedness in our local communities. Thank you.
Thank you, Dr. Chung, and I think you highlight many issues, but two, the technology issue and perhaps the opportunity for technology in the future and additional technology infrastructure, and also the issue of coordination and collaboration. Next, I would like to introduce Dr. Julie Morita. Dr. Morita is the Commissioner of the Chicago Department of Public Health. She was officially confirmed just a few weeks ago following 15 years of service to the department. As Chicago Department of Public Health Medical Director for Immunization, Dr. Morita fostered groundbreaking partnerships with health systems and the private sector, achieving national recognition for both the improvements in and overall coverage rates. Most recently, as Chief Medical Officer, Dr. Morita led the city's efforts to prevent the introduction and spread of the Ebola virus, including developing and launching the Chicago Ebola Response Network, the first local network of medical centers working jointly to prepare and respond to a possible Ebola case. As a result of her efforts, Chicago was the first jurisdiction in the nation to establish 4 CDC-approved Ebola response hospitals. Dr. Morita received her medical degree from the University of Illinois at the Chicago Medical Center. Dr. Morita?
Good morning. On behalf of the City of Chicago, Mayor Rahm Emanuel, and the Chicago Department of Public Health, thank you for having me here today, and thank you for this important opportunity to talk with you all. Specifically, I'd like to thank Representative Price, Representative Lewis, their staff, Shelley Hearn, and the staff of the Big Cities Health Coalition, and my fellow public health practitioners, Patrice, Jeff, and Wendy. I'd like to take a few minutes to talk about Chicago's work to prepare and respond to potential cases of Ebola and measles, specifically outlining how our city agency serves dual roles, both as a responder to public health emergencies, but also as a convener, bringing other parts of our public health infrastructure together to ensure our city and surrounding area are prepared. Neither of these roles would be possible without the support of Congress and the entire federal government. Indeed, it is the direct support that allowed us to be so successful in Chicago. Chicago is one of the 4 directly funded health departments, large urban areas, that's funded by the preparedness program. And it is only with your continued support that we will be able to prepare for the next public health emergency. As you know, Chicago is a global city, as measured by the sheer number of flights that take off and land daily at O'Hare Airport. O'Hare Airport is the busiest airport in the world, besting Patrice's just in the last year for the first time in a decade. So that together with Midway Airport in Chicago, bringing more than 91 million passengers to Chicago every year. This includes passengers from every corner of the world, including those from West Africa. Add to that a vibrant and active West African community living near Lake Michigan, near my home. We knew that as long as the epidemic continued in West Africa, our residents and our healthcare system would remain vulnerable. We started acting early, and we had the benefit of following and watching what happened in Dallas. We had regular internal meetings as early as August, just as the epidemic was gaining international attention, reviewing our protocols and plans and building the connections in the community necessary to ensure our city was prepared. Many of the healthcare facility collaborations that we had were based upon work that we've done through the preparedness program on an ongoing basis because we are directly funded. As the crisis worsened in West Africa, and within days of the Dallas patient being diagnosed, I remember people talk about they remember where they were when JFK was shot. I remember where I was when the patient in Dallas was confirmed. I was sitting in Hartsfield, actually, flying back to Chicago. And I remember thinking, oh my gosh, my life is going to change for the next months to come, and it's really, really true. But within days of that confirmation, because of the preparedness program we have established over the years, we were able to focus our preparedness staff and our resources to 4 key areas. Our entry point preparedness, because we have O'Hare Airport, community preparedness, health system preparedness, and intergovernmental collaboration. O'Hare was designated by the CDC as one of the 5 U.S. airports that would receive inbound passengers from the impacted countries in West Africa. Although the Customs and Border Protection Department was actually responsible for doing the screening as the travelers arrived into Chicago, we had a major role to play as well and established a team of staff out at O'Hare Airport as soon the day that the Customs and Border Protection screening occurred. And that staff was there to assure that we were able to identify people and facilitate the care of anybody who was identified that was ill upon entry into Chicago, but then also to make sure that we knew of those travelers who were staying in Chicago so we could continue to monitor them on a regular basis for the 21 days after arrival so we could make sure that they didn't actually develop Ebola symptoms. We also led a community preparedness effort, hosting town hall meetings for the West African community members in Chicago, and also hosting many informational and educational sessions for healthcare providers throughout the city. We actually had our staff walk door to door to over 600 clinics within the city of Chicago to hand deliver clinical guidance and respond to questions that the healthcare providers might have about the risk of Ebola and evaluation of patients with Ebola and what to do if they were worried that they saw somebody with Ebola so they knew where to call. Though it was highly unlikely, we wanted to make sure that every one of those offices knew how to respond and that we didn't end up with problems with disease transmission that was unnecessary. Those efforts tie closely with our hospital healthcare system preparedness efforts. Mayor Emanuel and the Chicago Department of Public Health convened a meeting of the largest hospital systems within the city of Chicago, and to make sure that they were able and equipped to respond appropriately. From that meeting, the Chicago Ebola Resource Network was born. This is the 4-hospital network that Patrice mentioned earlier, which is made up of University of Chicago, Northwestern Hospital, Rush University Medical Center, and Lurie Children's Hospital. Those 4 hospitals stepped up and said that they would work together as a network to make sure that we could evaluate patients who were suspected of having Ebola and also provide ongoing care to those patients if they were confirmed to have Ebola. Because we had been preparing, because we had established relationships with CDC, over the weekend, so they committed to this on Friday. The following Monday, we had a CDC team in Chicago evaluating each and every one of those hospitals to make sure that they had the adequate resources, they had adequate policies and protocols in place so that they could care for the patients safely without putting their own healthcare workers at risk. It was really been a very heartening experience to work with these hospitals. When you think about what entities I just described to you, they are usually competitors in the city of Chicago. They are not collaborators. And to get them to work together and to work out a rotation where they would each take a patient, if it came from the community or if it came from O'Hare Airport, was really heartwarming. And so I think what we've done is we've built upon that relationship for other non-infectious disease emergency type of situations within the city of Chicago, and we're really looking forward to working with them on that. But I think they surprised themselves in how well they could actually work together. Though we have screened hundreds of patients in our airport and monitored scores in our city and evaluated 8 possible cases distributed throughout the network of hospitals so no one hospital was overburdened, we have not had a case of Ebola. So for you, Wendy, my heart goes out to you for all that you experienced during that time. That said, if we did have a case, I am confident that we have done everything that we could possibly do to prepare. And I do believe a lot of that has to do with the fact that we are directly funded for a directly funded city. Our Ebola preparedness efforts exemplify how our agency has acted as a responder, providing staff on the ground at O'Hare, actively monitoring patients, conducting hospital trainings, going door to doctors' offices, and also as a convener, bringing major hospital systems together to the table to work together, working with the CDC and Customs and Border Protection, and activating and engaging our West African community. Public health should be both a responder and a convener. Ebola is a disease we need to be prepared for. The nations ravaged by Ebola highlight the need for a strong public health infrastructure at all levels to ensure this health and safety of our communities. The West African cities did not have a strong healthcare or public health system. Because of Congress's support, though, our cities strengthened their preparedness, and we have been able to build public health networks and infrastructure that is saving lives, provide staff at the airport and throughout the city actively monitoring individuals returning from Ebola-stricken nations. And that we've ensured healthcare providers and first responders have developed and practiced protocols that allow them to evaluate and care for patients while assuring the safety of their healthcare workers. We were also supported to create and print and distribute materials in English and in French to our West African residents in our city. In the past 2 months, we've received an additional $5.3 million to support our Ebola response. These funds will be used to strengthen our contact tracing, monitoring capabilities, increase training for hospitals and first response teams, help us to establish data systems that will support monitoring a large number of contacts. We'll also be able to use the funding to strengthen our infection control capabilities in our healthcare facilities and also our first responders. Ongoing and consistent emergency preparedness funding is critical to our healthcare system so that we have the infrastructure, resources, and staff to respond before a crisis starts. If not for the additional Ebola funding, we would have seen a decline in preparedness funds this year. Before concluding, I do want to talk a little bit about measles. Because of my background as immunization program medical director for over 12 years at the city of Chicago, measles is a disease that is near and dear to my heart, or prevention of measles is near and dear to my heart. The federal government also helps us prepare by finding robust immunization programs. And again, the city of Chicago is a great beneficiary of the funding. We get directly funded for our immunization program as well. It ensures that our residents, particularly our children, are safe. In 2000, the U.S. declared that measles was eliminated. In February 2015, we had a cluster of cases that were diagnosed at a daycare center in suburban Cook County, which is just outside of Chicago. 12 of 15 cases were among children under 1 year of age. There was an index case was less than a year of age in a classroom of all children under 1 year of age, so none of them had received their measles vaccine. So when we identified the first case, we knew it was just a matter of time before the rest of the child's classmates actually became ill, and it was true. Within a week, 11 of his classmates actually became ill. CDPH worked with the county, the state, and CDC to identify people suspected of having measles, contacted others who had been exposed, ensured their immunization status, and then we also monitored them as well. Some of what we applied in Ebola actually had helped us to monitor these other patients as well, or these other contacts as well in this situation. CDPH also coordinated 2 webinars reminding healthcare personnel about how to diagnose the disease, what testing to do, what to report to the health department, and also about the importance of vaccination. Even though we feel like this is core to what we all do and healthcare providers do, it's never enough. We can't rest assured that people don't need to be reminded, and so we did this. What I thought was really striking is that within a week of the case being diagnosed, we had 2 webinars with nearly 1,000 healthcare providers who participated. So to us, that was a remarkable response, but it was a testament to infrastructure that we had established because of the immunization funding that we receive on an ongoing basis. Because of the herd protection that we have in place, because of the strong immunization program that we have, the cluster did not spread outside of the daycare center. Because the adults worked at the daycare facility, all of them were immunized. Most of the parents of the children were immunized, and most of the people in the community were immunized. We had no disease spread, and we were very, very fortunate. I think Jeff has more information about how bad measles spread can actually be. So CDPH relies on federal immunization funding to conduct surveillance for vaccine-preventable diseases and to assure that our children have access to vaccines regardless of their ability to pay. We also use the funding to educate both the public and also healthcare providers. This funding is critical to our children's safety. In order to keep our protection strong, we need to ensure that all children have access to vaccines and our disease control systems are robust. In conclusion, we all know the question is not, will there be another public health emergency? The question is when. This is why ongoing, consistent federal support for preparedness and response and immunization work is vital to our big cities. In Chicago, nearly 100 million people travel through our airports every year. They bring so many wonderful things with them: economic opportunity, knowledge sharing and expertise, entrepreneurial spirit. Gifts that are allowed our city and nation to grow and thrive and become the place that it is today. But it only takes one of those 100 million people to bring a virus or disease with them into our city, whether Ebola, measles, or something we don't even know about at this point. That's why we need to be prepared. And that's why we need an ongoing commitment from the federal government to support our efforts and keep our city and our nation safe. Thank you.
His medical degree from the Uniformed Services University of the Health Sciences School of Medicine, and a Master of Public Health from the UC Berkeley School of Public Health. Dr. Jeff?
Good morning. Thank you for that kind introduction. It's a real pleasure to be here. On behalf of the Los Angeles County Department of Public Health, I really value this opportunity to come speak to you about our experience with measles, and I really want to thank the Big Cities Health Coalition for organizing this to provide you information. You know, we're talking about a set of diseases here that really do matter, and I hope you all feel this personally, because what we're striving to do is create communities that are really healthy and safe. We're talking about 2 diseases today, measles and Ebola, really where the norm in our community is to have 0 cases. And to provide a little context about this, many of you know that smallpox was a severe problem for many years. That was eliminated nearly 40 years ago in 1977. Tremendous success of an international public health effort. Another major health problem was polio, which you know has been eliminated from the Western Hemisphere for many years, and there's a concerted effort by the world to eliminate that. There's still some countries where that poses a threat. And measles is close in that category. Measles is a major killer of children throughout the world, and we as a nation were able to eliminate this, as Dr. Morita just said a few minutes ago. So think about this. These are diseases that have been major challenges, and we're really close to eliminating them. And so as a nation, we're continuing to struggle with how we implement these final strategies that continue to keep our communities safe. And so as the big cities with resources and lessons learned from these, we bring these to you so you have a good understanding of what we're trying to do here. So as a result of my talk, I hope you understand a little bit more about how measles happened. I realize here in the district, while you did have some cases, you didn't experience it like we did in Southern California. I also want you to appreciate that measles is a serious disease. I hope you understand that there's really 2 strategies that we have to try to contain measles outbreaks. One of those is under my control, and we do all we can, and the other one really isn't, and that's where I need your help and support in enabling us to be better protected. So I think you all know about measles. Looking around the audience here, I assume that most of you have never had it. I had it as a child, but it could be that there might be one or two others here that haven't had it. So none of you have personal experience with this because it's just a very, very rare disease, but it is very serious. In nations where there is no immunization program, up to 3 or 5% of children actually die when they get measles because they're severely malnourished, and measles is a disease that can lead to their death. Here in the U.S., of course, that's not exactly the case, but it is a very severe disease. Many of you know that it causes a cough, it causes a runny nose, you get red eyes, and then about the 7th to 10th day, you develop this rash that begins on your face and spreads throughout your body, and then you're very ill for quite a while. Most people recover and immune for the rest of their life, but a small percentage of people develop very severe consequences. They develop pneumonia, they develop an infection of their brain called encephalitis, and 1 in 500 or so will actually die from this disease. So it is a very, very serious health problem. It's also very infectious. So out of the 40 or 50 people in here, let's say 10 of you aren't immune and I actually was ill with measles, it's likely 9 of those 10 people would actually come down with measles as a result of being in attendance today. So it's very, very infectious. So what happened in California? Well, as many of you have heard, we first became aware of this a little over 100 days ago. On January 7th, the California Department of Public Health released information about an outbreak of measles that had started in the Disneyland parks in December. When they looked at the cases, all of the initial cases that were identified had been in Disneyland on one of 4 days between January 17th and January 20th. So then over a period of the next 2 months or so, there was a total of over 160 cases throughout the nation. This spread to affect 19 states and also the District of Columbia. In the state of California, we had over 130 cases. So there were 42 cases directly from exposure at Disneyland parks during that 4-day period in Disneyland. There was another 30 cases in California that were direct contacts or worked closely with those cases. There was another 15 who just happened to pass through an area where one of those cases had been. They had no direct contact, but became infected. And there was another 31 or so for which we could never figure out how they were exposed, but we're certain that they were exposed as a result of those initial cases. In LA County, we had, in our jurisdiction, 28 cases of measles. We have 2 other health departments in the county, Long Beach and Pasadena. They had 6 additional cases between them. Of these cases, 14% were hospitalized. And one of the cases was very severe. So out of 28, one of them was an adult who ended up in intensive care for an extended period of time with very severe pneumonia and who is still getting some occupational therapy because of the symptoms and problems that that person had. 11% of these folks were healthcare workers because where do people go when they're sick? They go into a clinic, and so of course healthcare workers are going to be exposed. The mean age was 22. While we talk a lot about this is primarily a childhood issue, in fact over 60% of the cases were adults, over 20 years of age. And 54% of our cases were not vaccinated. Now, just remember, we're in the midst of this Ebola thing at the same time while measles is going on, so I still have my 10 to 12 cases I'm monitoring a day, and people with fever, of course this is flu season, and people with fever are very common, in LA County with 10 million people. If we have 10% influenza, that's 1 million people with fever, and then there's all kinds of causes of rash. So you can just imagine teasing out these 20 cases of measles in the context of all these other things going on is very, very challenging, even for a health department like ours. So while we ended up with 28 cases, we actually had 450 individuals we suspected had measles. People with fever and rash, and we had to do an investigation. And on top of that, we ended up with over 2,200 contacts. So just imagine between the period of the first week of January and the first week of March when the last case occurred, that's about 40 to 50 individual contacts a day that we have to investigate. It's a huge amount of work. So then I'll talk about that a little bit more. If you haven't heard, the outbreak was officially declared over 2 Fridays ago on April 17th. That day is determined because it's 2 incubation periods since the last case. The last case actually had rash onset in early March. If you add 42 days to that, that puts you up to April 17th. And so the outbreak was officially declared over on that day. There's a lot of roles that public health departments have in responding to an outbreak like this. I think most of those roles have already been highlighted as we've talked about Ebola quite a bit. But it really, I hope you appreciate that it really is the public health departments that really are leading the response in the community to get them back to the point of being safe and healthy, which is what we're all here about. So the first role we have is providing information, as has been said. So for measles, I convened a couple of press conferences, got all the media there, we get our website going, I hold webinars. I've got 27,000 licensed physicians in the county. How do I reach out to them? I've got 100 hospitals, 88 school districts, 80 cities. It's a real challenge to reach out all those communities and provide them the information about what's going on, clarify for them what roles they have and what the tools are we're providing to help them do that. So that's a big role. It's really extraordinary amount of work. Then there's clinician education because, you know, doctors haven't seen measles. So somebody could walk in with a fever and rash and not even think of it. So we have to provide them information to think about that. And then, of course, as they suspect the diagnosis, they need to know who to contact, and we provide the laboratory testing to support the diagnosis. Then there's the surveillance role. So we have to have all of our antenna up to try to detect cases as they occur so that we can quickly identify them and confirm them as cases. And then there's the work of the actual case investigation and the contact investigation. So a primary strategy of preventing further spread is isolating somebody who's infectious. So we want to identify that case immediately, put them at home or wherever they can be, and restrict their activities so they don't expose others. And then, of course, all those contacts, we look at them to monitor if they develop illness, because we'd be concerned about that. We also actually would quarantine them. So if they're going to go to work or they're going to go to a school, we're going to say no until you're through the 21-day incubation period. You're restricted from certain activities. And so we monitor them to make sure that that is done. In addition, some of those individuals are actually eligible for preventive therapy. Some of them could be vaccinated or receive immune globulin, which would prevent them developing measles. But that tends to be the exception because it would have to be identified within very few days. So to respond to an outbreak like this, you kind of understand what we need. We need adequate staffing. You know, one of the challenges in Los Angeles County, most people speak a language at home other than English. So over 5 million people are speaking Spanish or Chinese or another language. So we have tremendous challenges just in translating messages and providing an appropriate cultural context and so on and so forth. But there's a huge amount of staff that are needed. We also need clinical staff because we have to talk with the clinicians in the community and communicate what's going on and provide diagnostic support as needed. Communication staff, as I mentioned, is very important. We also mentioned the information management challenges. These really are overwhelming. As has been discussed, we use what's called the incident command system, which is a nationally recognized approach for health departments to efficiently organize and respond to emergencies. I've led our incident command system several times over the last few years, including Ebola and some other things. So we immediately got into this mode. I have about 40 staff who directly are part of that, and then we have scores of other people in the department who are helping us with the investigations and with the information management. It's really a huge task, and LA County is one of the few health departments actually in the state that has these kinds of resources to do this. We also do the lab testing. We have an extraordinary public health laboratory in Los Angeles County. The kinds of tests that are needed to diagnose measles, polymerase chain reaction test, which is very specific for that, is not a test that's available in clinical laboratories elsewhere. So this is something that's very valuable. When we stood that up, then other counties around us were able to use that laboratory in order to quickly make diagnoses and make decisions on how to manage people. Some of the other things you need to know is measles is a respiratory airborne transmitted disease. So if I had measles and I left here, the virus would continue to float in this room for up to a couple of hours. And so when they go into care facilities, our partners need to have negative pressure isolation rooms where they can put these individuals so they won't spread and affect other patients or staff who are working there. And of course we need a large stockpile of immune globulin and vaccine. I will mention that the 317 vaccination program, which is something that I know is scheduled perhaps for some cuts, was very helpful to us because it does allow us to use vaccines to immunize adults and children who otherwise aren't covered by certain programs. So that was a very valuable asset to us in responding to this outbreak. So, as I said, there's really two ways in which we respond to measles. One of them is the work we do, identifying the cases, identifying the contact, hopefully isolating them and preventing further.